I didn't mean to make it so no one wanted to talk.
Well, I think Pete should say what he had said in our email today because it was the perfect verbiage, and I certainly don't remember it to repeat it. So if Pete, you could start, that would be fantastic.
I don't remember exactly what I
You
said.
said it like an open house, kind of.
Yeah, I thought we could kind of have, yeah, like a sort of an open house, kind of a discussion more than a presentation like we normally do for these. Just because it's sort of the legislative session has ended. We're, as Rana said earlier, it's sort of the dog days of summer and we're kind of in between projects. So it just seems like a good time to regroup and maybe with the people who are here, talk about what we have on our minds, what we see as opportunities for areas of focus moving forward, and see if we might be able to come to some kind of consensus about what we should focus on for the rest of the year and in the year ahead. Whether that might be, I know in the last few months we focused a lot on sort of state level healthcare access things like capitation, Husky for Immigrants, stuff like that. We did some labor solidarity work with the rideshare drivers union. And in years past, of course, we've done more advocacy at the national level, talking to Rosa DeLauro's people and Johanna Hayes's people about federal Medicare for all. We've done local stuff with the resolutions. So, there's all kinds of stuff that we have done in the past, and it's to sort of offer guidance. And like I said, it seems like a good time to kind of figure out where we want to focus moving forward. So that was what I had in mind, more or less.
Perfect. I agree. So if anyone would like to start with any comments or ideas, we are more than open.
I actually think it would be a great idea to do some, in-person, just events, I know there was, some kind of, this is before I was involved, but it was like a few years ago, there was like it's like a town hall or something. And I think it would be great because I feel like the conversation around Medicare for all, like it was like really prevalent like a few years ago, and then it's kind of like started to die down. So I think just like kind of getting it back out there. Yeah, maybe like having in-person events now that we can, getting hopefully some local press around that, inviting legislators, would probably be a good idea. I'm mostly going to keep my camera. I'm eating burritos, which are like messy. I wrap them myself. So until I'm done eating, I'll probably keep my camera off so you don't have to see me eat my messy burritos.
That's okay, Donna. We don't mind messy burrito eating, but I think that's a really good idea. Just, being out there more in person, doing more events and things like that. Great idea. Thank you, Donna. Go ahead, Zach.
Yeah, I was about ready to post this in the chat. I assume folks have seen this article on the hearing about insurance rate increases that is coming up on the 21st. But in case you haven't, I'm going to drop it in here. I assume it would be of great interest. I was, of course, upset to see that.
Yeah, their nerve yet again. Ridiculous. Thanks, Zach.
Yeah, I just posted the article in case anyone hasn't seen it.
Much appreciated.
Well, yeah, when we started thinking about this, chatting over the last day or two, I wondered if it might be helpful to think about what we might want to do on the national level and then on the state level and also on the municipal level, because, it's a fight that has a lot of different fronts. And I think we've largely focused on the state, primarily in this group. You know, PMHP has done more work on the national level, and we've been supportive. But you know, we had been supporting municipal resolutions more a couple of years ago than we are now, and whether that's worth, you know, pursuing again to just build the constituency, not just citizens, but municipalities pushing their representatives to do something because of the budgetary burden of providing health insurance for city employees and city retirees. So, you know, I don't think we have to really separate it all tonight, but we might want to think about ways we can pick up loose ends in all those different, you know, arenas, national, state, and local.
Kind of reminds me of one, kind of on both. We had some success passing municipal resolutions in Hamden and New Haven, which were big efforts and took a lot of time and effort and great work from everybody. And part of the idea when we were doing that was, you know, once we passed these resolutions in kind of like the backbone of Democratic support in this part of the state, New Haven and Hamden, we were going to go back to Rosa DeLauro's office and go back to maybe Chris Murphy and some of those people and say, like, look, there's support for these policies. Would you rethink your support now? Which we never really did. So that might be a good thing to follow up on, is finally trying to make inroad, set up another meeting with some federal legislative offices and point to those successes that we had at the local level.
Yeah, I'm in
Patricia.
Hamden, and I remember we voted on that, the legislative council voted and all of this stuff, and then it just kind of died an unnatural death. Nothing's happened, and you know, it's gonna be like next to impossible to get Rosa DeLauro to move on that because she's in the pocket of the capitalists, so. There you go. I was hoping that something would happen after, but I have no idea what we could do with it.
Well, even if we could just nudge her to be a little more vocal about her public option plan, I think that would be progress. Because she kind of introduced it, and then the only thing she's ever done with that is kind of point to it when people give her a hard time about single payer.
Yeah, I think that's all it's for.
Yeah, I mean, I think you're right too, but if we could nudge her to at least pretend like it's an actual proposal, because it's not actually a bad bill. It's not as good as, Medicare for all total single payer, but it would be a good, if it happened to pass, it would be a huge improvement.
Right.
So if we can get her to
It
move
would be a
towards,
step, is what you're
yeah.
saying. It would be a step.
yeah, and her staffer, when we did talk to her a few years ago, said like that was kind of the idea, was instead of ripping the Band-Aid off all at once with Sanders like Medicare for all bill, the idea was to kind of let the insurance industry die on the vine by just nudging people over time into the public plan. And there are reasons to be skeptical of that approach, but it's not completely nonsense. And if, like I said, if we could just get her talking about that, I think that would be a good thing.
So how do we get her talking about anything?
Yeah, I mean, or just nudge her toward that.
Yeah.
In the past, we've been able to talk with her policy people. So, and I think before we were just a handful of people kind of hectoring them, but we would still be that. We could also point to, these big legislative efforts in New Haven and Hamden and say, like, look, this is, town councils have passed these, town DTCs have passed these are young up and coming Democrats. This is the future of the party. It's the way the wind's blowing. We got all this support from your constituents, just like on the ground, rank and file Democratic Party voters.
She has to see all that,
want.
otherwise she's not going to be convinced.
Sure, yeah, but it's
So
what we got.
yeah, I mean, I think your idea is great, but it needs to be splashier, because she's not going to move on anything if she thinks she can just ignore it.
Yeah, but to Pete's point, I don't think that we have bothered her enough, so to speak. I don't
Okay.
think we've had our voice in her ears enough, so to speak. I just don't think we've been annoying enough to her or her people.
Right, and I think that's what I'm trying to
So
say.
I
yeah.
don't think it needs to be flashy. I just think we need to be annoying.
Okay, I think I
And
was trying to avoid the word annoying because
yeah,
I'm
no,
already an
no,
annoying person.
You do.
No,
You
yeah.
need to be annoying in order to
Yeah.
get someplace sometimes.
Yeah, and
Um,
I don't want to
Well, I think
suggest.
that's really what I meant by splashier.
Yeah, and I don't want to suggest we can have one sit down with a staff member and like that'll be it. That's
Right.
Obviously, that's not going to be the case, but just start following up on some of the seeds we've planted and try to
For sure.
try to sow or reap some of what
Absolutely.
we've tried to sow.
I think that's a great idea. So
Yeah.
Phil, did I see you go to put your hand up earlier?
Yeah, since we're open right now just to get different topics. I got a very interesting letter about concerning from the Connecticut Department of Health concerning transactions involving group practices. And it was a pretty sternly worded reminder that a law passed in 2014 under the Malloy administration requires that transactions involving the sale of group practices require a certificate of need, just like if you want to put in a new CT scanner or build a new clinic, you can't do it without a certificate of need. And I think the motivation behind that is because of is backlash against the massive incursion of private equity into the practice of medicine. And if a private equity company is trying to buy a practice, then they, without a certificate of need, which can be denied, which can prevent them from buying that practice. And I'm not sure exactly how this links to Medicare for all, but I think it's a very important development, and it'd be interesting to brainstorm a bit to see how we could that story, that fact to what we're trying to accomplish with Medicare for all.
Well, from what I can gather, this would have to do with cost. So if more and more people and huge, private equity firms buy these group practices, they can continue to raise prices and raise our costs. And we don't have anything to say about it because they have this huge private equity, they're buying up everybody. And it does mean a lot because they're driving costs up. And who controls that? I'm not 100% certain, but I know that I'm pretty sure that OHS, Office of Health Strategy, has something to do with that, with the certificate of need. Sheldon is here. He may not be able to come on camera, but he could probably type in the chat if I am correct or not. But this is a huge issue, and it's a problem. It's a real problem because then they close down things and places like, the maternity wards that they were closing down in the upper part of the state, and this is a real problem. So this really is intertwined for sure, and it's an equity issue, it's an access issue, it's a cost issue, it's an everything issue. So it would affect us because we don't just do, our thing, but we want to make sure that we help advocate for everyone and getting access and quality services as best as possible.
Well, and also to get away from medicine for profit. My wife is an internist, and I were having a discussion, and you've heard of Envision, which is a private equity company that apparently has bought up about 70% of all the ophthalmology practices in Connecticut.
Wow.
Ophthalmologists are very unhappy. And to my knowledge, they did not apply for a certificate of need for any of those transactions. And part of this letter was a reminder that there are significant fines that accumulate on a daily basis for failure to comply. And in order to, if you're not sure whether your proposed transaction falls under that law, there's a specific form to fill out to send to the state, and they can tell you whether they think it applies or not. So there's no excuse for, oh, well, I didn't know. We'll see if they actually carry through with this, and if it has any follow through. But if it does, I think it's going to be a good sign for trying to stop the encroachment of private equity on medical.
No, when we were talking about the resolutions and putting pressure on, the members of Congress like Rosa DeLauro and, where I am in the second district, Courtney is really just as uninterested. One of the things that I think we envisioned at the beginning of this resolution campaign is to also use that to put pressure on our state legislators. Our model in Connecticut, at least, was the fracking waste bans that were being passed all over the state about, I don't know, maybe 6 or 7 years ago. And when about 50 towns passed bans, the state legislature took action. So I think 5 towns in Connecticut passed Medicare for All resolutions: New London, Wyndham, New Haven, Hamden, and Stamford, I think, are the 5. But I don't know if we can get 10 times that number. But if we had 50 and the municipality, the town councils were talking to all their state reps about doing something in Connecticut, that could help. And I think it might have been at a PNHP meeting that there was discussion of right now supporting the Medicare for All bills in the House and the Senate, Sanders and Jayapal's bill. But in fall, Ro Khanna will be reintroducing his state-based bill, I believe. And, that's worth supporting too. It actually has a conservative talking point there. It's like it's a states' right issue to not put obstacles in front of states that want to do this. So there's even a case to make with states' rights Republicans to support the Ro Khanna bill. So Connecticut has, in a way, a good start by having a public Medicaid program. So in some ways, we're in better shape. Of course, we're the insurance capital of the world, so that tips it back in the other direction. But I think the resolutions may be able to be used to make headway on a state level.
Have a public Medicaid system, a private-based Medicaid system to establish that. That was a real accomplishment.
So does anyone else have any ideas or questions or things that they would like to see happen. Does anyone know a really good organizer who may want to volunteer their time with us? Because we are really, really in desperate need of a volunteer organizer. And if you know of anyone, that would be fantastic. You know, just keep us in mind, and you can send anything to us at info@medicareforallct.org. And Ronna and I get those emails, and we will respond to them as soon as we can. But we would love to hear anything from you guys. Sheldon, I know that there's an issue that's coming up soon. Another primary care roadmap issue, I understand, being named something else, but still the same. Did you want to talk about that too?
Okay, but can I respond to a couple things you said? Or
You
is that,
absolutely can. Absolutely go for it.
on the private equity aspect, I don't believe any of the hospitals, some of them are for profit, but I don't think any of them are private equity owned yet. I'm expecting that will be around the corner, but they're merely for profit. And of course, Yale New Haven and Hartford Health act as their for profit anyway. But one thing that I've been working on is it's sort of a niche area of private equity in healthcare, is something that most folks would not have even thought of probably, but it's relevant to my work representing people with disabilities, and that is wheelchairs. So you wouldn't know, unless you read an article in Mother Jones a few years ago, you wouldn't know that the wheelchair supply industry has been gobbled up massively by two big companies, private equity owned. And they have, like in Connecticut, they have the entire market, two companies. In Massachusetts, those same two companies have most all the market. And in several other states around the country, it's the same. So private equity works it's basically the same as for profit, except that they plan to make money in two ways. That, you know, the main immediate profit way is you produce so many widgets and you get a lot more money than you put out making the widgets, and keep the difference. And private equity certainly works like that. But the other thing is private equity is investment for the future in terms of hopefully packaging this entity and then selling it. So it's not just you're making money today, but you're making it look really, really attractive to somebody else, to some other corporate entity or a set of private equity, another private equity investors. And so everything is geared towards that. So the sort of combination of those two things makes for a pretty nasty stew. And then you add in the lack of accountability, because at least with publicly traded companies, they have to do SEC filings. And in there, you learn a lot of information. Some of it's misleading, but you learn a lot of information about the company. Private equity is like completely insulated from that. So not naming names, but say the spouse of a particular governor who makes all of her money in that area, specifically private equity in healthcare. You can do all that and it's all secret. I mean, yes, it was disclosed about Saudi Arabian, and what investor, but it's really a problem. So it's a massive development. And I do think this is what people were talking about before, that it's sort of like a symptom. The fact that private equity is making huge inroads into healthcare is a symptom of the fact that the whole system is a mistake. That the whole system is built around essentially profit, and therefore, well, let's make money too on it, right? So what is going on with primary care under Medicaid? And I would say this is for a whole 2-hour topic, so I'll make this really short. When Ellen Andrews, who you know, and I worked years ago to show the door to our lovely for-profit insurers who are running Medicaid, the point was that capitation creates really bad incentives because, the incentives did not provide health care. That's the whole point. Your medical loss, if you're publicly traded, they would report their medical loss ratios. And of course, now that's required outside of Medicaid. It's required reporting. It's not required in Medicaid. But anyway, they would brag about how low their medical loss ratios are, which of course is a sign of a really unhealthy system because a lot of the money is not going to healthcare. They would brag about that. So, our point was that capitation of these insurance companies is not the way to go if you want to deliver healthcare. And I'm sure most people agree that applies to everybody, but particularly low-income people on Medicaid who are really vulnerable, who don't have the means to pay out of pocket when the insurer says no, don't have the means to pay, like at the pharmacy when the insurance company denies, payment for a drug for lack of prior auth, don't have credit cards to get the drug. So we won in 2012, and now our system is one of, I guess, 3 states in the country that don't have capitated managed care, private capitated managed care running their Medicaid program. The state keeps the risk, and it contracts with ASOs, administrative service organizations, to do things like prior auth and customer service and provider credentialing. So that's great. But what's happening is that's okay. We'll just move it down the lateral. Okay. So what we could do is we could capitate all the providers, big providers. So instead of the insurance risk, the risk being had by insurance companies, we could just move the risk down a rung to, say, nonprofits, such as Hartford Healthcare, little nonprofits like that, and Yale New Haven Health, or for-profits like Pro Health. And they'll do a great job because we're going to, by putting that financial risk on them, they'll have the incentive to keep people healthy. And basically this concept of moving capitation down a level has been around for a while. And specifically in Connecticut, it's been focusing on the Medicaid program and primary care. They'd like to capitate the whole damn thing. I mean, they would like to just go to Hartford Healthcare and say, here's the dollars per member per month. And then Hartford Healthcare acts just like the old managed care companies. It's the same thing. It's just that one's called Hartford Healthcare and it's technically nonprofit. That's what they like, but they're not going to get that. So they're trying the smaller thing, which is to capitate primary care. And it's been a fight that I've been involved in, Ellen's been involved in for, like, at this point, in one form or another, about 6 years. And Holly's right that they use different terms. Capitation has gotten such a bad word by people like us. So they stopped using it and they came up with a new word called prospective payment, which means capitation. There's a footnote in their report, the roadmap that she referred to. There's a footnote that says, by capitation, by prospective payment, we mean capitation. But we're not going to use that term any other time in this whole document, 25 times, because we don't want you to know that. The latest iteration is that DSS, it's a big agency, there's different views, but unfortunately, the powers that be at the Department of Social Services, which runs Medicaid, wants to push this capitation thing. So rather than going through, some of you may have heard of the Medical Assistance Program Oversight Council, or MAPOC, it's like the entities required by federal law to have a sort of broad-based entity which oversees and is presented with potential changes in delivery, healthcare delivery, payment, all that stuff, to review that and provide advice. They don't control, it's just advisory, but to give advice to the agency about whether it's a good idea or not, what to look at and all that. Well, this entity, the problem with the entity is there's lots of different people on it who are appointed by all different legislators, Ds and Rs, and House and Senate and others, and the governor, and it's kind of broad. Well, that's a problem, because if you want to rig something, you don't want a broad set of people, right? So they handpicked everybody on this, and with the exception of Ellen, everybody is either they're in one of three places. They are state agency people who push these models. They work for Hartford Healthcare or Yale New Haven, or maybe I'm not sure about Pro if they're represented, but entities that have been basically making noise that they support this and want this. And by the way, if they want it, it's because they think they can make money on it, meaning they think they can make more money by getting the capitated rate and then denying service than they get from the straight, fee for service. That's the calculation. They think they can make more money, otherwise they wouldn't be supporting it. Anyway, it's those kinds of entities. Or, for example, Mark Schaefer, who works at the Connecticut Hospital Association, which mostly represents Yale New Haven and Hartford Healthcare, and was this is religion to him. This is like he believes in this more than anything. And when he for years he was the, you want to call it brains behind the state agency that was pushing these models. Now he's at the Connecticut Hospital Association, so he's on it. And then the third group is people that look like us, meaning that they're advocates, except for one little thing. They work for entities that either now or recently in the past have gotten lots of money from state agencies that want these models. So it's the membership is completely rigged into doing it, but they don't call it capitation and they don't call it prospective payment because that also got a dirty word. So now it's population-based payment. They're proposing population-based payment. What does that mean? Oh, that's a per member per month payment for all the healthcare. That's their latest, lovely version. And the way it's justified, and this is all, I don't know if the term is Kafkaesque or Orwellian, but this is a good thing because this model gives flexibility to providers to provide all the kinds of services they've always wanted to provide to their patients, but couldn't because of the rigidity of the fee-for-service system. That's the language, that it gives flexibility to providers to provide additional services. Let me translate that. It means that providers can now provide whatever services they want 100% out of their own pocket, just like they do now, or can do now, and generally don't. And so now it's the same, except that every dollar of healthcare they provide will come out of their pocket. Every dollar, not just extra stuff, because it's entirely capitated. So if you don't see patients and you get the cap rates, you keep all of it, right? There's an argument, well, they won't do that because A, they're ethical. Providers are ethical. They're doctors, after all. They've taken an oath, so they would never do that. And second, they wouldn't do that because it doesn't even make any sense financially, because they'll get sick. If you just ignore your patients and don't bring them in, they get sicker, and then you end up paying for they get really sick, they go to the hospital, they go to specialists. No, you don't. You're a primary care provider. They go to the hospital, it's not on you. But in any event, I think the first thing is more of the lie, because yes, doctors take the Hippocratic Oath. I think they generally take it seriously. I think most doctors are quite ethical. But the problem is that increasingly, of course, doctors don't work for themselves. They work for a corporate entity, which may be PE owned. I didn't know that about ophthalmologists. And they're not, unfortunately, they're not the masters of their own destiny anymore. They take instruction from a boss who's, they used to be doctors. The administrators used to be doctors, these things. Now, increasingly, they're not. So those people never took an oath. And those are the people who tell them what the rules would be. As far as when they make an appointment, when a patient calls and says, I'd like to make an appointment, what are the standards for whether you give them an appointment or not? That's not their call, increasingly. So the whole premise of this thing is, in my view, bankrupt. And we're trying to fight it. And it is difficult because they have created this rigged entity. So we're going to be working at, the public messaging, attacking this and, explaining that that thing about flexibility isn't flexibility at all. It's just, the freedom to give away free stuff. Great. Thank you for the freedom. So that does that answer your question, how I explained it? after I've had the floor for way too long.
Thank you, Sheldon. No, I'm just, it makes me worried. This whole situation worries me. And I wanted to make sure that everyone that was on this call understood that this was happening yet again. And they were trying to get one over on us yet again. And that we may have to ramp up letter campaigns and join forces and build some power around this situation to really try to stop it yet again. So I thank you.
Thank you.
Sheldon, do you have an article of reference that you could put in the chat? Because this is a amazing topic, and I'd like to spread the word amongst my friends.
There's been no articles yet about this initiative. It's been kind of quiet. I think Ellen will be doing, she does have a gig on CT News Junkie, and she writes an op-ed every once in a while. I think she's going to be doing that. But last year, because this is an old story, we've been fighting this in one form or another for years now.
Sure.
And the primary care capitation Medicaid, it's been this big boogeyman. I'll try to find, but I did with CJ, some of you know, Catherine John, Black and Brown United in Action. We did an op-ed in the Hartford Current. That was when there was a legislative proposal that would have authorized the Office of Health Strategy that Polly referred to as having total authority to basically do all kinds of alternative payment models, namely this. And we did successfully defeat that as a legislative authorization. As you see, it's still happening. They're still trying to do it anyway, but at least we defeated it as a legislative authorization. While we're talking, I'll try to find that Hartford Current op-ed, and if I find it, put it in the chat.
I know that's a whole lot of information. Does anyone else have any questions or comments on going over, possibly doing more resolutions? Trying to get in touch with Rosa DeLauro's office or Courtney's office, or let's see. Any questions that Sheldon may be able to answer other than what Phil had asked? So there's just important things going on, and now we're all really busy, and hopefully we'll get started again soon, more frequently, and everybody will be all done because school's starting. So hopefully we'll all be in a better rhythm. I'm hopeful to find an organizer who wants to volunteer. I will continue to say that every chance that I get.
Is it possible that someone involved with PNHP might be able to step in and do that? Like maybe somebody who's just been involved there, but not, I don't know, but is maybe looking to have a bigger organizing role. I don't know if that would be possible.
I don't think that at this point, the Connecticut chapter has the capacity to do that either. But it's certainly worth looking into for sure. That's a very good idea, Donna. Thank you.
I just wanted to share one other thing. Medicare for All Connecticut is a 501c4 organization because when we got together, our thought was to work on legislation in Connecticut and maybe nationwide. But we're also looking into creating a 501c3 arm that would be more research oriented, because trying to get various bills through the state legislature, we have found that they don't want to allocate any money towards proving that a nonprofit system will save money. And so we feel as though we might have to fund independent studies and present the results. And research other aspects, I don't know, but just for an education and research arm to this organization, we are looking into different umbrella organizations to sponsor a 501c3 or some other alternative so that we can actually have the capacity to do more research ourselves. Ooh, I guess I have one more question for people. It seems like this is kind of winding down. Would it be useful if we put together some kind of, survey to send out to people to find out what aspects people are most interested in working on, which level legislatively, what basic issues, and then kind of compile it and figure out who can work together on what?
I had the exact same thought. I think that'd be a good idea to send it as a follow-up email.
Well, we'll have to put it together first.
Well,
but-
yeah.
So we'll take a couple of days.
I don't mean like
Yeah.
right after the meeting, but after, just not
Yeah.
immediately.
Yeah, I was looking, thinking about this meeting ahead of time, and like just the general theme that came to my mind was like, we need to start getting organized to get organized, to getting organized. We're not really getting organized yet, but we're thinking about how we can get organized for the coming, fall and winter. So, getting a handle on the different aspects of the problem we have to confront, and also figuring out who wants to do what are parts of that.
Would it be helpful to have like a strategizing meeting, like a meeting that's just devoted to like, okay, what are our resources? What, what are people interested in? What can we do? And just like lay out like a few steps for like, okay, this is what we hope to accomplish in the coming year.
I think so. I'm not thinking, I don't think that everyone who comes to the monthly meetings, especially when we have speakers, would be interested in being in on it. But I think everyone who wants to be in on that planning, we should figure out a time to get together, maybe in September.
Patricia, I'm not familiar with what paywall is. What is that?
No, I'm just responding to I pulled up the current article and it splashed this thing on there. You have to get a subscription.
Oh, okay. I was
I
like,
wanted to
what?
pull it up before we close the meeting because then I won't have the link, but
Oh, okay. Okay.
so it's a wall you have to pay to get through.
They are offering the deal though, $1 for 6 months. So just grab it.
It may not be a lot of money, but it's more than I can afford.
I haven't
Understood.
done it either. They're just hyping it.
So, before we close out, does anyone, as you can see, I've taken a ton of notes. Does anyone have any other ideas, questions, concerns, comments, anything? Pete or Rana, do you have any final comments?
No, I think that about covers it for me. Thank you, everybody.
Yeah, thank you.
Yeah, that's same here. Thank you guys so much for being here and sharing ideas and thoughts. And, you know, Sheldon will make sure he keeps in touch with me and well, through work and whatnot, and I will keep everybody apprised. And, you know, we'll fight this together yet again.
And
So thank you.
whatever the new term is, we'll make that one go out of fashion too.
Population-based payment. So, yeah,
Gotta love it.
thank you guys so much. Have a great rest of your evening. We gave you back 9 minutes.
Have a great night, everybody.
Take care,
Thanks,
guys.
good night.
Thank
Bye.
you. That was very helpful, very interesting.
Good. I'm glad you enjoyed it.
Thank you.
Bye, Zach. I'll see you soon.
Yes, indeed. Take care.
Bye. You too. Bye-bye.